Good afternoon, everyone. Today we are going to discuss about fever and its pathophysiology. So the topics which we are going to cover in today's discussion are pathophysiology of fever, how we are going to define fever, what is febrile response, and everything about fever, stages, grades, patterns, causes, and how we are going to assess fever and manage it further. Okay, so let us discuss first about the pathophysiology of fever. What is thermoregulation? Our body temperature is going to be maintained around a normalcy. Okay. What is a normal body temperature? It is around 37 degrees Celsius, which is equivalent to 98.6 degree Fahrenheit. Okay. It is maintained around 37 plus or minus zero point 0.5 degrees Celsius. This is the normal physiological variation which is permitted normally, and it happens because of either diurnal variation or menstrual cycle in whatever phases the person is. Based on the cycle of menstruation, there can be normal variation, or the level of activity of the person, the age of the person. Based on all these things, there can be normal variations in the human temperature. So this in this range of normalcy, the temperature is usually maintained by the thermostat, which is actually the preoptic compartment in the hypothalamus. It either activates or activates the heat gain mechanism or heat loss mechanism, whatever it is, but it maintains the temperature in this normal range. So let us say, for example, a person is working in a very hot climate. Okay, what is going to happen? He is going to wear a light cloths, cotton clothes, behavioral changes, and he is going to sweat a lot. Okay, in a hot climate, his body is going to respond by sweating a lot. Why it is happening? It has to maintain the temperature in the normalcy. So it is activating a heat loss mechanism so that he can be maintained in the normal value. Suppose, let us say, for example, a person is exposed to a cold climate. Behavioral changes, what we expect of him is to wear layers and layers of clothing like mufflers, overcoat, whatever it is, and he is going to shiver. Shiver is a mechanism of thermogenesis or heat gain. So, in a cold environment, in order to maintain the normal physiological temperature, the person's heat gain mechanism is activated. So, this is how the normal thermoregulation is taking place. Okay. However, in case of fever, this temperature rise is going to be beyond that normal exertion, like beyond zero point 0.5 degrees Celsius, the temperature is going to rise, and this is attributed to substances called as pyrogens. See, in the word itself, it is pyrogen, genesis of fever. Okay, so let us define fever. The fever or pyrexia is defined as elevation of the person's body temperature which exceeds the normal daily variation, and this is going to occur in conjunction with the hypothalamic set point. Okay, so first the person's hypothalamic set point is going to rise, and in order to meet the hypothalamic set point rise, the person's body is going to respond in a certain way, and his temperature, whole body temperature, is going to be raised, and this we are going to measure using a thermometer, and we call this as fever. Okay, so this fever is actually a regulated process which happens in conjunction with rise of hypothalamic set point. Okay, next another thing is there is a AM and PM variation, or a morning or diurnal variation, as we have already discussed when we were talking about the normal thermoregulation, right? Similarly, when we are defining the fever, we have to consider this AM and PM variation also. So a person is said to be febrile if his morning temperature is more than 37.2 degrees Celsius and his evening temperature is more than 37.7 degrees Celsius. Okay. Or if you have to say in Fahrenheit part, he is considered to be febrile if his morning temperature is more than 98.9 degree Fahrenheit or his evening temperature is more than 99.9 degree Fahrenheit. So let us discuss about the components which are involved in the febrile response. Okay. First one is exogenous pyrogens. So some of the examples of this exogenous pyrogens are lipopolysaccharides, which are part of the bacterial cell wall, and viral components or toxin parts of the pathogens like hemagglutinins, etc. These are some of the examples of exogenous pyrogens. Once these pyrogens enters the body, it is going to trigger response by endogenous pyrogens. Earlier it was known as endogenous pyrogens. Now we also call them as pyrogenic cytokines. Examples of pyrogenic cytokines are interleukin 1, interleukin 6, TNF alpha. All these are examples of pyrogenic cytokines. Okay, so these levels are going to be increased in the body, everywhere in the body, and since the circumventricular organs in the brain are lacking in the blood-brain barrier, it is going to easily cross and reach the brain. Okay, and one of the organ is organum vasculosum of lamina terminalis. This part is very close to the hypothalamus. Okay, so, and in the brain, as a result of this pyrogenic cytokines, there is going to be production of prostaglandin E2 biomechanism. We already know COX is involved in the production of prostaglandins. So, arachidonic acid present in the cell membrane is going to be converted into prostaglandin E2. The levels are going to be raised in brain as well as in periphery. In because of the peripheral PGE2, you are going to experience symptoms like myalgia, arthralgia, which are usually associated features in fever. And in the brain, it is going to raise the thermogenic set point. Okay, so the next component is prostaglandin E2, which is going to act with the receptor EP3 receptors, and it is going to raise the set point in the hypothalamus. The last component is hypothalamus. So this is the pictorial representation of a febrile response. So you can see the entry of pathogens here. So let us take a pointer. So this is the entry of pathogens. So once the pathogen comes into the body, the exogenous pyrogens, that is the lipopolysaccharide, cell walls of bacteria or virus, whatever it is going to trigger the immune response. And as a result of this, the pyrogenic cytokines, interleukin 1, interleukin 6 and TNF alpha, it is going to increase. And the level in the brain is going to raise. Because of the COX mediated production of prostaglandin E2, the fever is going to be produced. So we will see what is happening in the hypothalamus. You know, the hypothalamus has the thermoregulatory center. So the production of PGE2, it is going to act on the EP3 receptors in the hypothalamic regulatory center. As a result of this activity, there is going to be elevated set point. So the thermostat, internal thermostat is set at a higher point. So normally it is at 37 degrees Celsius. Now it is elevated to 39 degrees Celsius. Now the body has to respond by either heat gain mechanisms like shivering, peripheral vasoconstriction so that the body's blood can be directed to the core organs, whatever it is, by whatever means the body is going to raise the temperature, and this is manifested as fever. So this is what is happening. Let us say the body's temperature or the set point, okay, the thermostat set point is set at a higher level. Like for example, here it is set at 103 degree Fahrenheit, okay. So now the body is going to respond by the mechanisms which heat gain mechanisms like shivering, peripheral vasoconstrictions, etc. so that it can reach the set point 103 degrees Celsius Fahrenheit. After reaching the set point, it is going to reduce by heat loss mechanisms like sweating or vasodilatations so that it can reach the normal temperature. And this happens in several stages. Gradual increase, and there is a plateau phase followed by a defervescence where the fever is decreasing. We will see the stages of fever now. So these are the stages of fever. Okay. So let us see. There is a gradual rise, which we call it as stadium incremental. Then after reaching the set point, the fever is going to remain there for that is known as plateau phase or stadium acmes. Following that, the fever is going to reduce because of taking some antipyretics or whatever, the person's immune system winning over the pyrogen. it is going to reduce either gradually or suddenly, and that phase is known as stadium decrementi. Okay, so this is stadium incrementi, plateau phase, and stadium decrementi. The fever reduction can happen either gradually, which we call it as fever reduction by crisis, or it can happen suddenly, which we call it as fever reduction by lysis. So we can grade the fever based on the temperature readings on the thermometer. We can grade it as low grade fever or high grade fever. Between 37.5 to 38, it is usually considered low grade fever, and beyond 39.4 degree Fahrenheit, we can consider it as high grade fever. And B41, we call it as hyperpyrexia. Okay, so we have to understand what is fever, what is hyperpyrexia, and what is hyperthermia. So fever is a regulated rise in core body temperature. Okay, it is going to happen in conjunction with the set point rise. Hyperpyrexia is an extreme rise in temperature beyond 41.5 degrees Celsius, and it happens in situations where there is CNS hemorrhage or severe infection. Okay. Hyperthermia is entirely a different entity. It is an unregulated rise in body temperature, and it does not happen in conjunction with hypothalamic set point rise. One of the example is a person experiencing a heat stroke or taking some neuroleptics, where some psychogenic drugs which causes neuroleptic malignant syndrome. There are certain drugs which can cause production of heat without rise in the set point temperature. Okay, and it will not involve the normal febrile response which we discussed earlier, pyrogen, COX, or PGE2 production. All these things will not happen in hyperthermia. So let us first discuss about causes of fever. So fever can be because of infectious causes and non-infectious causes. So what are all the infectious causes? It can be a bacterial infection, fungal infection, or viral infections, or parasitic even. Non-infectious causes is autoimmune, malignancies, and drug fever. These are all some of the non-infectious causes of fever. So daily we are going to monitor the temperature in a temperature chart. And based on the temperature chart reading, we can find there is a certain pattern of fever. Okay. In certain temperature charts, the markings usually return to the normal value. Okay, the temperature returns to the normal value, and we call them as intermittent fever. In certain types of fever, the temperature will not return to the normal value. It remains above it. It can be either continuous fever, or it can be it can be continuous, or it can be remittent. The difference between the two is the daily fluctuation in the temperature. Here the fluctuation is less than 1 degree Celsius, whereas here the daily fluctuations is more than 1 degree Celsius. Now we will see how we are going to clinically assess the fever. We are going to measure the temperature using thermometer, and there are organs which reflects the core body temperature. Examples of them are rectal and urinary, esophageal, and pulmonary artery. These are organs which reflects the core body temperature, whereas they are not clinically feasible. We have to usually measure the peripheral temperature in the peripheral area, and these include tympanic membrane, axillary area, etc. So the central will be core body temperature is reflected in rectal, esophageal, bladder, pulmonary artery, and peripheral temperature in the oral, tympanic membrane, axillary area, and temporal area. So these are some of the sites of peripheral measurement of temperature. So tympanic membrane, so temperature, and axillary area. Here they are sweeping across the forehead, which is nothing but reflecting the temporal artery temperature. And these are examples of digital thermometer. Other modes are infrared and mercury thermometers are also available. The next one is clinical assessment, which is basically history, general examination, and systemic examination. In the history, we are going to take a detailed thing about the fever onset, duration, whether it is acute in onset or chronic in onset, and what are all the patterns. Every other day, every third day, whether it is quartan fever, tertian fever. So this is going to give a clue. In malarial fever, there is a pattern, typical pattern, and diurnal variation. For example, let us say there is an evening rise of temperature for a prolonged time for more than 2 weeks. You usually consider thinking about tuberculosis and associated features, whether there is chills, rigor, which usually points towards a pyogenic foci. And based on the pyogenic foci and associated symptoms, you are going to localize which system is involved, whether it is cardiovascular, respiratory, or urinary tract, GAT, or CNS. Okay. And general examination. General examination will include pulse, respiratory rate, BP, and other external markers which suggest which could be the cause, infectious or non-infectious or tuberculosis, malignancy, or inflammatory disorders. Okay. And talking about the general examination, there is a thing called the Leibermeister rule. Okay. For in fever person, for every degree rise in temperature, every degree Celsius rise in temperature, the pulse rate is going to rise by 8 to 10 beats per minute. Okay. And talking about the respiratory rate and temperature relationship, for every degree rise in temperature, the respiratory rate is going to rise by 4. Okay. So this is the general rule. There can be some exceptions. Okay. In certain fever, there can be relative bradycardia, and we call it as Fagett sign, which is seen in yellow fever, typhus fever, brucellosis, leptospirosis, some dengue fever, Q fever. There are certain conditions where there is relative bradycardia. And also there are certain conditions where there is relative tachycardia. Especially when carditis is there, there will be relative tachycardia. We have to know about it. Okay. See, some person who's having sepsis will have raised low BP also. We call them as septic shock. And we already saw the relationship between the temperature and heart rate and respiratory rate. Focused examination of each and every part. So rod spots will be seen in infective endocarditis. Oral cavity we have to see for tonsils or any pharyngeal abscess, something like that. Lymphadenopathy is there or not. Splinter hemorrhages will be seen in infective endocarditis. So any other pyogenic focus in the abdomen, lung fields. Okay. And in the nervous system we have to check for Kernicks and Brudzinski for meningitis purposes. Similarly, we have to have a focused system examination. And in a person having inflammatory causes or autoimmune causes of fever, there will be external markers like butterfly rashes, scleritis, joint deformities, okay, Boutonniere deformity, swan neck deformity, and in psoriasis there can be nail changes, dystrophic nail changes, and rheumatoid nodules. Okay. So similarly, these are the external markers which are seen in. So based on these external markers, you can have a fair amount of idea what could be the cause of fever. Okay. And the host factors have uh, um, some kind of role in febrile response. Not all person will have a brisk febrile response. Old age, infants, person with chronic kidney disease, those who are on steroids, and immunocompromised persons. All these persons, they will not have the normal febrile response. Rather, they may be having type hypothermia at presentation. So you have to be very careful while you're taking history and take into consideration these host factors before deciding whether to work up for this patient or not. And how we are going to manage fever? So, see, you have to know in fever, febrile response, COX is involved. Like production of prostaglandins needs COX. Arachidonic acid is converted into prostaglandins because of these enzymes. So, you are going to inhibit this COX enzymes by COX inhibitors, and you call that as antipyretics. Some of the examples are aspirin and acetaminophen. In the hyperthermia, the febrile response or that system is totally not involved. The production of elevation of temperature is because of external environmental change or something like that. Here, antipyretics will not work because it is not involving the normal febrile response mechanism. So you have to know about it. And talking about the antipyretics which we commonly use, it is paracetamol. You have seen, right? Dolo 650 or paracetamol 650, 500 milligrams. It is given every QID. In a QID dose, it is given. Recommended dosage is 650 for an adult person every fourth hourly or sixth hourly. Other NSAIDs like ibuprofen can be used when with paracetamol the control of temperature is not attained. You can add ibuprofen to it. So 400 milligram every sixth hourly. And in case of hypothermia, physical cooling techniques are used. Ice packs, tepid sponging, okay, ice bath or blankets can be used. So this is how you treat a hypothermia patient despite antibiotics, without antibiotics. Thank you.